Dear colleague, dear friends, it's a great pleasure to welcome you to this podcast, educational podcast by EAHAD. My name is Cedric Hermans. I will be running this activity with my friend and colleague, Robert Klamroth. The topic of today is how to manage acute cardiovascular disorders in patients with haemophilia. Hello, Robert.
Hi, Cedric. Nice to be here with you. I just remembered when I started haemophilia treatment 25 years ago, my teacher told me thrombotic events in patients with haemophilia are impossible. What do you think?
Well, this is not longer true, Robert. We know that some of our patients can present with cardiovascular events. Well, certainly it's quite unusual in young patients, but we now have a much larger populations of older patients, and we know that these patients might develop several comorbidities. Any kind of internal disease, cancer, but also cardiovascular disease. This is clear. And there is an increasing interest in looking at this cardiovascular disease. And I would like to emphasize the fact that, hemophilia A and B have always been considered as providing some degree of protection against thrombosis. But this is probably not true. Patients with hemophilia can develop venous thrombosis. This is quite unusual, but our patients can also develop arterial thrombosis. Robert, is this your experience too?
Yes. And do you think, Cedric, it's mainly because the population is growing older now with the new treatment possibilities? Or do you think that maybe patients with hemophilia have the same or even a higher risk to develop atherosclerosis?
Well, it's clear that our patients, they are getting older, but it's also obvious, and many studies have looked at this, that our patients with hemophilia can have one or even multiple cardiovascular risk factors. And although it has always been considered that there would be lower mortality because of hemophilia, that could be a little bit mitigated by the fact that these patients have multiple cardiovascular risk factors. And nice studies have looked at this, and they've clearly shown that, yes, patients with severe hemophilia are certainly protected against cardiovascular disease. Well, they are still at risk. It's not a very frequent event, let's be honest, but this is something that can happen. Not only myocardial infarction, but also ischemic stroke, although it's quite unusual. Well, clearly patients with severe disease have probably a high degree of protection. Patients with mild and moderate hemophilia might be less protected. And there have been many studies looking at this, and it's difficult to give you an overview, especially in this kind of podcast, but sometimes the results have been more or less conflicting, showing similar prevalence or higher prevalence. But globally, when you look at all these data collectively, clearly our patients with hemophilia are at risk of developing cardiovascular disease. And you remember, Robert, myself and yourself, we took part in several studies, including a large study that looked at this across Europe. And we came to the conclusion, yes, that patients with hemophilia, their prevalence of coronary heart disease is probably less. This is what we found. But we also came to the conclusion that these patients are at risk of ischemic cerebrovascular disease and stroke. So we need to pay attention to this. And what seems to be critical, in my view, is that our patients with hemophilia are certainly at risk of developing hypertension. And this is an observation that has been made in many, many studies. So if we want to summarize this, I would say that our patients with hemophilia can develop atheromatosis. And why is it like this? Because our patients with hemophilia do have hypertension, they might have diabetes, they might have high cholesterol, they might have family risk factors for cardiovascular disease, they might be smoking. And on top of that, they might have a sedentary lifestyle. So altogether, these patients will develop atheromatosis. The question is, will these patients develop atherothrombosis, which is, the generation of a clot on top of this atheromatosis? And here, it's very likely that hemophilia does provide some protection. But this is something we could discuss also later on. It's clear that when you treat your patients prophylactically, or when you give our patients new agents, they might lose to some extent this degree of protection. And as a result of that, our patients might be at risk of developing unstable angina, myocardial infarction, stroke, critical leg ischemia, or even die abruptly because of this. So this is important because when our patients do develop this atherothrombotic complication, well, they will need some sort of treatment and many antithrombotic treatment. And this is the next topic that I would like to discuss with you. How do we manage this? How do we manage this, Robert, in our patients who need antithrombotic treatment? So maybe you could share with us a clinical case illustrating this that you have had recently in your practice.
Yeah, Cedric, that's good. And I would ask you for advice how we could deal with this patient. And that is a patient with severe hemophilia A with multiple cardiovascular risk factors like overweight, arterial hypertension, smoking for long years, absolutely no sports. And of course, he had severe hemophilia with arthropathy and total knee replacement. And this patient was admitted to the emergency care room with acute myocardial infarction. And how to proceed, Cedric? Do you have any idea how you proceed in these patients? What would you recommend?
Well, we would like to do everything possible for this patient. And well, the good news is that we now have some guidance. We have limited evidence, but many of our colleagues have tried actively to provide us with some guidance. And if I'm correct, well, I would like to do my best to treat these patients I would like to treat another patients without hemophilia. But I assume that if I want to do this without problem, I will have to correct this hemophilia. So I would need to give concentrate. Would you agree with me?
I think that's really important, Cedric, that we treat these patients with acute myocardial infarction like normal patients without hemophilia with myocardial infarction. And with correcting the hemophilia, we can deliver them for PCI, we can implant stents, we can do the acute treatment. I think that's very important that hemophilia should be no reason not to do PCI and cardiovascular revascularization. And that was exactly what we did in these patients. But unfortunately, he had severe coronary heart disease and an aortic valve insufficiency. So an interventional treatment was not possible. Would you recommend that these treatments, as in patients get heart surgery?
Well, I think that if it is needed, yes, let's do everything possible. I think we have the treatment. We have the treatment to offer this patient the best treatment. But I agree with you. We'll have to balance very delicately the risk of thrombosis and the risk of bleeding.
Yeah, that's crucial. But you all know in hemophilia surgery is possible with the right coverage of factor 8. And that's what we did with his patients. He got 3 coronary artery bypass grafts and an aortic valve replacement and did very well after surgery. On long-term prevention, of course, we have the question, how do we deal with antiplatelet treatment in these patients? What would be your recommendation, Cedric?
Well, clearly, maybe a first question to you, because I noticed that you did decide to, what sort of valve was used in that patient? Was it a mechanical valve or bioprothesis?
Of course, we try to avoid a mechanical valve because anticoagulation is very difficult in those patients, and we implanted a bioprosthesis.
Okay, well, I think that makes sense, and that would be a recommendation that we would make to the colleagues listening to us. Well, clearly, if these patients will need some sort of antithrombotic treatment, and I think that, well, clearly we'll have to correct his hemostatic defect related to his hemophilia much more or less intensively. I would say that if the patient needs a high degree of anticoagulation, or if the degree of platelet inhibition is high, well, I think that we should try to maintain the factor levels to a higher level. I would also say that if we only inhibit platelet with a single agent, maybe we should just make sure that this patient has a permanent factor 8 or factor 9 above 2, 3, 5%, I would say. Would you agree with me?
I fully agree. And that was exactly what we did with these patients. We put him on prophylaxis on regular prophylaxis to be able to treat him with antiplatelet treatment. Unfortunately, this patient developed atrial fibrillation later. And would this change your anticoagulation regimen in a patient with severe hemophilia and prophylaxis, Cedric?
Well, this is a very difficult question. How do you manage this? Well, I think here again, as we did for the discussion before, we need to balance the risk of thrombose and the benefits of antithrombotic agents in this patient. I think this is very important, and we should also not forget that our patients, because of their hemophilic status, do have some natural anticoagulation. In my view, they might be naturally protected, even if they have atrial fibrillation. Would you agree with me?
I think that's a very important point. And I guess now, Cedric, we should review the recent literature. Is there anything which can guide us a little bit? Is it safe to do anticoagulation or antiplatelet treatment in patients with hemophilia? Do we need certain thresholds of factor VIII activity in hemophilia A? And are you aware of any guidelines concerning this, Cedric?
Well, clearly, one of the most updated documents are the guidelines of the WFH published in 2020, but there have been other important guidelines published by other groups recently. And I certainly invite our colleagues listening to us to watch the video that we developed about this, because we tried to put together the most recent guidelines currently available.
Yeah, so Cedric, that's my recommendation too. For the last part, look in our webinar, which is on the EAHAD Academy website. You will find the latest studies and recommendations about anticoagulation and antiplatelet therapy in our patients with hemophilia.
And I think the message is clear. In all our patients with hemophilia, when they get older, we need to make sure that we assess all the cardiovascular risk factors. I think this is quite important. And we make sure that these patients do not develop arteriomatosis, and always take into account the potential risk of arteriothrombosis. I think this is critical. And if you had to conclude with a final message about antithrombotic treatment in these patients, Robert, what would you say?
I would say all our scores to have a risk for atrial embolization in patients with atrial fibrillation are not made for patients with hemophilia. So the reflex to anticoagulate every patient with atrial fibrillation with hemophilia is not right. And you said it already, some patients with severe hemophilia A and prophylaxis are still naturally anticoagulated. And so it's an individual decisions. And in our webinar, we give some guidance how to deal with these patients. So it's always an individual decision for the individual patients, how much anticoagulation is safe and needed in our patients.
Considering that we now have plenty of new therapeutic agents for hemophilia that allow us to give antithrombotic treatment much more safely than in the past. Well, Robert, I think it was a great discussion. I hope it was helpful for our colleagues, and don't hesitate to watch the full video on the EAHAD website. Thank you, and hope to have the opportunity to talk to you again in the future. Bye-bye.
Bye-bye.